I'm Dr. Vijaya Nitin Balvalli, a consulting anesthesiologist. We are going to talk about local anesthesia at the moment. In this digital era, if any one of us were to Google anesthesia on our smart digits, the sentence which goes through is anesthesia is the controlled and reversible or temporary depression of sensation and awareness for a medical purpose. Each of these words in this statement have to be taken very seriously. It's controlled by a health professional. It is reversible. I just cannot leave you into a state of decreased sensation and awareness and leave you there permanently. It has to be reversible or temporary, and it has to be done for a specific medical purpose. Any of these two things done, decreasing your sensation and awareness, not for a medical reason, is not anesthesia. Having gone into this definition of anesthesia, let us see who is this person who is going to control your anesthesia. Do we really know who administers anesthesia to us? When any of us are having a health problem, we walk into the consulting chambers of our doctors, maybe the next door family physician, or any of the specialists like a physician, surgeon, eye doctor, ear doctor, gynecologist. We read their nameplates, note down their qualifications, and we visit them quite very often to know and have a personal relationship with them. But an anesthesiologist is a person whom you will rarely visit because he does not address your health problems per se. And you will rarely see an anesthesiologist in his consulting chamber. These are professionals who are 99% of the time found in the operation theater settings, in the pre-anesthesia room, in the operation theater cubicles, in the post-recovery room, with their operation theater clothes, cap, mask, gown, wandering about, looking at the patients, examining them, taking them into the operation theaters and looking after their recovery. These professionals are health professionals. They are doctors per se. The basic four elements of anesthesia are four. One is analgesia, which means relief from pain. The second is amnesia, which means loss of memory of that event. The third is paralysis, which means that part of your body should not move. And the fourth is unconsciousness, which is the only part we as lay people understand because we said behosh ho gaya, or the person is unconscious. That is a state in which we are comatose, not in control of ourselves, and somebody takes charge of us. The anesthesia part is dealing with the main controller of our system, the central nervous system. The nervous system by itself is divided into two parts, a central nervous system and an autonomic nervous system. Autonomic nervous system, although very important in anesthesia, is beyond the scope of this talk, and so we will limit ourselves to central nervous system. The central nervous system is made up of two parts, the brain and the spinal cord. The brain enclosed in the skull, which is known as the cranial cavity, and the spinal cord enclosed in the vertebral column or the backbone, which stretches right down till our body. This being the central nervous system, the nerves which are created in this brain and spinal cord move away from there and migrate to the most distant parts of our body, innervating practically every cell in our body. When these nerves travel to the different parts of the body, they become thinner and thinner, like the tributaries of a river, and innervate everywhere. If we have any sensation anywhere in our body, it may be heat, cold, touch, pain. These nerves take these sensations from that part of the body to the brain. These nerves which take the sensations there do perform the function of sensory nerve. It is taking the sensation. The brain, by its own previous experience, interprets this sensation as heat, cold, pain, touch, and it gives the order. This order is carried by the motor nerves to that part of the body, and the action of removing our part of the body from that particular hot or cold object is achieved. We either remove our finger away from the hot object, or we clothe ourselves in warm clothes when we feel cold. So hence I have told you what is the sensory function, what is the motor function. So some nerves are sensory, some nerves are motor, and some nerves have a mixed function. They do both the things. When any small part of the body requires anesthesia and this peripheral nerve is blocked, that is local anesthesia. Local anesthesia can be applied only to a small portion of the body where that particular peripheral nerve is blocked. It could be dental peripheral block which the dentist gives you. It could be a small, maybe suturing to be done on any particular part of the body. So that area is blocked. This block can be achieved either by giving an injection there, or by applying a local cream, or by applying solutions. Or if you would remember, when you have a severe throat pain and you go to a doctor, he gives you gargles. These gargles also contain local anesthetic or analgesics, painkillers for you to relieve the pain and to make that area numb. This is your local anesthetic. When a very small part of the body requires anesthesia and the patient need not be subjected to a greater level of drugs or intervention. It has to be a very, very small procedure, as I told you. It could be a tooth extraction, it could be some dental treatment, it could be a small cut in any part of your body which has to be given a few sutures. This is the peripheral nerve block, and this is local anesthesia. Going further from here, if it is going to be a larger area of the body which requires anesthesia, for example, if my arm, forearm, my hand requires some anesthesia, where I need not be made totally unconscious, this is regional anesthesia. Now, in this case, what happens is the spinal cord, as I told you, are sending out nerves. These nerves, which come out of the spinal cord, join with one another, again divide and redivide. When they join together, they form something called a plexus. When any such nerve plexus is blocked, it becomes a regional block. If my hand has to be anesthetized for some reason, then the anesthesiologist can give me a regional plexus block, which is called an axillary block, where the plexus is in the axilla, or it could be a supraclavicular block, where the plexus is above the clavicle bone, which is there on our neck. If it is something which has to be done on the leg, the anesthesiologist could give me a femoral block, whereby most of my thighs and legs could be anesthetized. The two important regional blocks which people are aware of and normally they talk about is the spinal block, the spinal arachnoid block, where you would see in local terms, people would say as they got a prick on the back. Now, this prick on the back is literally called spinal anesthesia in medical language. Now, what is this spinal anesthesia? From the spinal cord arises nerves which travel outside, as I told you. The brain and the spinal cord are enveloped in a fluid which is known as the cerebrospinal fluid, or CSF. In a space called the subarachnoid space, which covers the spinal cord, the anesthesiologist will give you a prick on your back in between the vertebrae and inject the local anesthetic in this cerebrospinal fluid space so that the part of your body below that level becomes totally anesthetized. This spinal anesthesia is used in many surgeries where the surgery has to be conducted below the umbilicus. It could be a cesarean, it could be an hernia hydrocele, it could be prostate in males, it could be any orthopedic surgeries done in the lower limbs, it could be piles, fistula, fissures. This is spinal anesthesia. Very similar to spinal anesthesia, but a little difference in technique is the epidural anesthesia. This epidural anesthesia is given in the space outside the subarachnoid space, and there is no CSF there. It is a blank, empty space. The needle is put in this space and the local anesthetic is injected, and the effect achieved is similar to spinal anesthesia in that the lower part of the body or the part of the body from that level is totally anesthetized. The anesthesiologist is in total control of the amount of area that should be blocked by these two techniques, and the technique can be slowly changed, altered, or made to see that the level of anesthesia achieved is as per the comfort of the patient. This epidural anesthesia, a further word about this epidural anesthesia I would like to put on is, in a spinal anesthesia, it's a one-shot injection and the injection would wear off in a matter of an hour and a half. In certain cases where we do not know how long the surgery is going to last, if we use an epidural technique, a small fine catheter can be threaded into the epidural space and kept. One more aspect of this epidural analgesia is what you would be hearing in modern days, that it is used as labor analgesia or obstetric analgesia, where the patient gets relief during her labor pains. This epidural analgesia helps to a great extent the mother who does not have to go through the labor pains. And for any reason, if the delivery does not progress and you have to go ahead with an operative session of an LSCS, the same anesthesia can be continued without more pricks and pins being put into her, and the gynecologist or the obstetrician can go ahead with a scissor section. Local anesthesia is only the blockage of peripheral nerves. Spinal anesthesia, epidural anesthesia, and the different blocks of the plexus I told you form a part of regional anesthesia, where a large area of the body gets analgesia, which is the primary function of anesthesia, gets a paralytic effect where that part of the body cannot be moved. So the two purposes of anesthesia which we spoke of, analgesia and paralysis, is achieved. In addition to this, these patients who are subjected to local anesthesia or regional anesthesia, to keep them calm, to relieve their anxiety, to put them into a little sleeping mode, agents for sleeping, sedatives, are injected through the patent IV setup for the patient, because almost all the patients who are going to for anesthesia, peripheral vein, peripheral IV setup is kept ready. So the patient is sleeping, is less aware of the surroundings and completely pain-free, because either of the local anesthesia or the regional anesthesia. These are two different types of anesthesia, local and regional. They are two different types. Whenever we talk about local anesthesia or regional anesthesia, in both these cases, the drug which is administered is a local anesthetic agent. The local anesthetic agent delivered at the peripheral nerve end and the local anesthetic agent given at the spinal cord level. It's the local anesthetic for both these things. The dosage and the concentration of the drug would change as per the requirement of the patient in terms of weight, in terms of constitution, in terms of the time duration required. That is left tailor-made for each patient. Now, what are the contraindications for giving it? Any person who is allergic who has a known history of allergy to any of these drugs should not be given these agents. So that is why preoperatively the history of allergy to any of these drugs is taken, and before the surgery we do a test dose of these local anesthetics on these patients to confirm that they are not allergic to any of these drugs. Any local infection which is present in that area would prevent us from injecting the drug there, because that would cause the spread of the infection. The indication for this, as I told you earlier, a very small area to be blocked, peripheral nerve block, would be much better than subjecting the patient to general anesthesia, which would require more drugs and more discomfort to the patient. The regional anesthesia, which I spoke of, spinal and epidural, are useful for all surgeries below the umbilicus level, because it involves a large part of the body from the umbilicus down to the tip of our toes. Many of the surgeries can be conducted with this anesthesia, which requires less drug consumption. The number of drugs used are also less, which you will realize when I talk about general anesthesia. The comfort level of the patient is high because the anesthesia wears away in an hour and a half. The patient is awake, patient is able to go back to a regular schedule of eating, drinking, if the surgical part provides for it. Because in certain surgeries, we may not allow the patient to eat for 24 hours. But if it is a small hernia or a hydrocele or any orthopedic surgery which has been done on the leg, then the patient need not be kept fasting for 24 hours. And after a post-operative abstinence from food for 3 or 4 hours, the patient can go back to regular eating and drinking. The precautions to be taken after spinal and epidural are: the patient should comfortably rest and be in the sleeping position for 24 hours. And these patients are comfortably sometimes able to get up and sit after about 5-6 hours of surgery, and they can go back to their regular routine. But yes, these people should not start mobilizing on the same day, should not drive or move about. Or if some of the surgeries are daycare surgeries, they should not, even if they go home with after a spinal, after 12 hours or 15 hours, it is better that they take rest for 24 hours and be comfortable.